I'm going to briefly discuss maternal early warning systems. Um, so, uh, in terms of my short talk, in terms of an outline, I'm going to start by uh, an overview of the different maternal early warning systems. There are several of these systems. The best known is probably the MEOWS system, the Modified Early Obstetric Warning Score. There's also something called the MUC, the Maternal Early Warning Criteria. And then finally, there's another system called MUTE, the Maternal Early Warning Trigger Tool. So I'll discuss these systems. I'll go through some data on the test characteristics, focusing on specifically how often do these systems detect someone who is going to have an adverse outcome versus what's the screen positive rate and the false positive rate. And then I'll briefly talk about implementation issues, which I think are important, and then just briefly discuss future research possibilities. So I think that the enthusiasm for maternal early warnings came from maternal death review committees and other maternal reviews a few years ago, which showed that for many maternal deaths, there was a delayed response to vital sign abnormalities. So for example, from this maternal mortality review from California, they found that for preeclampsia, postpartum hemorrhage, stroke, venous thromboembolism, amniotic fluid embolism, in the majority of cases, there was a delayed response to vital sign abnormalities. And the idea is that if you are aware that the patient is becoming critically ill, you could potentially intervene and avert the outcome. So soon after that death review came out, this report from the UK came out, and in their maternal mortality review, where they reviewed maternal deaths in the UK, they had very similar findings. They found that in many cases, the early signs of impending maternal collapse went unrecognized. And this was for several reasons. A lot of these deaths were from rare events. The patient population was generally healthy. And it was difficult for providers sometimes to discern abnormal from normal based on the physiologic changes of pregnancy. And so based upon that UK report, this early warning system was released. And if you were using a paper version, this is what it might look like. You chart the patient's vital signs from left to right, and if they're abnormal, they'll fall in a yellow range or a red range. And if they're two yellow alerts or one red alert, the doctor is supposed to be notified emergently, and then the doctor is supposed to come and evaluate the patient. And in terms of what goes into these early warning signs, it's pretty intuitive. When they asked a bunch of obstetric anesthesiologists what should be in the early warning, they all basically said the same thing. Temperature, heart rate, respiratory rate, blood pressure, oxygen saturation. So those are the parameters that go into all of these early warning systems. In terms of thinking about how an early warning system is supposed to work, there are a few things that have to happen, and there are a few things that can break down. First of all, the patient, number one, has to have their vital signs taken. The second thing is that these parameters have to be recognized as abnormal, and the doctor has to be notified. And then third, the doctor has to evaluate the patient and then have an appropriate plan for investigating what caused the abnormality. So when you think about it, there's kind of two components. There's the criteria, the early warning criteria, and then there's the effective escalation policy. What happens next when an abnormality is detected? And again, an abnormal parameter requires the physician to be notified, to come to the bedside right away, plan for a workup, and the provider really has to keep an eye on the patient until the abnormality resolves or they judge it to be of a benign cause, or if they determine that the patient's critically ill and care needs to be escalated, maybe the patient will go to, an ICU or some other higher acuity setting. And so that's kind of like the conceptual overview, but I think it's helpful to try to think about, specifically, what are we trying to prevent clinically? And I think it's just a short list. It's just a few things. We want to avoid delaying administration of antihypertensives for patients with severe range blood pressures. If a patient has severe anemia, we want to diagnose that. If a patient has a concerning cardiopulmonary process, we want to know that. And then, as per the last talk, if there's an infectious process or sepsis is developing, we want to know that as soon as possible. For all of these things, if we know sooner rather than later, there's a chance that the outcome will be better. There are some other rare conditions, but I think this list mostly covers it. So these are what the early warning systems look like. This is the meows. These are the parameters: blood pressure, heart rate. This is the MUSI. It's a version of meows that was used in the US. The criteria are a little bit simpler. They got rid of the yellow alerts. It's just red alerts. This is mute, kind of a complicated list of alerts. This is used kind of on the West Coast in the US, in a big hospital system in California and some other states. And then with this system, they have this very complicated algorithm, which, based upon what your suspicion is for the cause, you go down a clinical pathway in terms of management. I haven't used the system, but the people in California are a big advocate of it. So what's the evidence for these systems? How well do they work? I think that's the first question that everyone has. And there's some data now that's available. So this was the first study that I'm aware of that came out, and it was based on the meows criteria. It was a study by Singh et al. And so they looked at this composite of adverse outcomes. They looked at the things that you would anticipate: hemorrhage, preeclampsia, infection. And then using the meows criteria in this cohort of about 670 patients, they looked to see what the test characteristics were. So of the 670 patients, 30% triggered an alert. So that's pretty high. That's a substantial portion of the patient population. The sensitivity was 90%, specificity was about 80%, positive predictive value was about 40%. For the mute system, their sensitivity, they said for ICU care, was about 70% with a false positive rate of 20%. They said if you use their criteria, if they were persistent, the false positive rate goes down with similar sensitivity. When we looked at this data at Columbia, we did a similar study to the study by Singh. We looked at 500 admissions, reviewed their charts. We had our own adverse outcome, which was severe range hypertension, or lab abnormalities associated with hypertension, severe diagnosed anemia, systemic infection, and then some other adverse events. And when we looked at the criteria, we found the same thing, basically as Singh. We found that about a third of the patients were screened positive. So again, a pretty significant proportion of patients. And about 10% of patients had the outcome of interest. And it was mostly hypertension. About 2/3 of the cases were hypertension, but also some cases of severe anemia, infection, and other adverse outcomes. And I thought one thing that was interesting is when we looked at the different vital sign parameters, they yielded different results. So an elevated blood pressure was pretty good. About 2/3 of patients with an elevated blood pressure met some, had an adverse outcome that met criteria. But for hypotension, 4 out of 55 cases, hypoxia, 1 out of 14 cases, and tachycardia, 2 out of 34 cases, pretty low probability of the patient having some sort of complication. And then there were also 9 women who had a complication but didn't have any vital sign abnormality. So our conclusions from the 2015 data were pretty similar to the SYNC study, relatively high screen positive rate. Some vital signs performed better than others. And the majority of the clinical alerts were related to hypertension. We went back to look at our data in 2018. Instead of looking in the charts, we used the electronic health record. And with that analysis, we were able to look at many more patients. We looked at about 14,000 patients, and we created a composite maternal morbidity outcome, hemorrhage, infection, cardiac dysfunction, respiratory distress. And then we looked at the vital signs in the electronic record. And we looked at the different warning system, meows, musi, mute, and we found that the test characteristics vary. So if you look on the bottom, mute, pretty low sensitivity, but pretty high specificity. For meows and musi, higher sensitivity, but lower specificity. So, it does seem like with these warning signs, there is a trade-off. So that's our data. I just want to shift gears now to talk about implementation issues and some of the things that we've experienced. Again, like really anywhere along the pathway for these alert systems, there can be an issue. Maybe the patient's vital signs aren't taken at the right time. Maybe the person taking the vital signs doesn't realize they're abnormal and they don't alert the provider. Maybe the provider is alerted, but the provider is busy with another emergency, doesn't get to the patient. So really anywhere it can break down. One thing that was an issue at our hospital was alarm fatigue. Our data was that hypotension was a pretty bad predictor of adverse maternal outcomes. And so our residents, our house staff, they got frustrated pretty quickly getting phone calls for blood pressures in the high 80s systolic for patients who were totally fine. There were some issues with our hypertension responses that were less than timely. We used to require cardiac monitoring and house staff being present for giving IV labetalol. So that was helpful to uncover. We were able to find some systems problems that we were able to address. One barrier was need for re-education. So one thing we found that was an implementation issue was that you can't just do it once. At our hospital, it's a large hospital, nurses come, nurses go, nursing assistants come and go, house staff graduates, new house staff comes. And so there had to be continued education. And then there had to be someone who was constantly evaluating the process to monitor what the issues were as they came up. So it wasn't the type of thing where you could just implement the protocol and then you were all set. It was a constant ongoing process. And so I think the issues that we experienced are also similar to what's in the literature. So they did a survey again, asking people, what the issues are and barriers with implementing these systems. And they pretty much came up with the same types of problems that we came up with. So I'll just finish with some thoughts about how we could make these systems better, maybe. I think that in terms of how we set them up, where we have these different parameters, you can use different parameters, different cutoffs, but you're always trading off the false positive rate for better sensitivity. Maybe there are ways that we can predict risk better. Maybe using machine learning algorithms, which are really designed for risk prediction. So maybe all the information in the EHR just goes into a machine learning algorithm, and once a certain threshold is hit, the provider automatically gets an alert. Maybe that type of thing would be better. I have some colleagues who are doing that type of work for ICU patients now, where they're using machine learning to predict decompensation among ICU patients. So maybe that will be an opportunity to improve care. So to conclude, I would say that we have enough data now where we can say that there are probably some well-defined limitations of early warning systems. Specifically that you're going to have a trade-off between high sensitivity and low specificity versus low sensitivity and high specificity. So you can catch more patients, but it's going to be a higher false positive rate. I think there are definitely some benefits of early warning systems. With early warning systems, you really standardize in your hospital what everyone understands to be abnormal, and that's a good thing. Everyone is kind of speaking the same language. But again, limitations include alarm fatigue, and that you really have to allocate significant resources to responses. Early warning systems, they clearly have a benefit in identifying some patients that require prompt attention, but I think we still need to do work on refining which parameters need to be included. Should abnormal parameters primarily associated with pathology be included when the patient is symptomatic? So, for example, if someone's hypoxic, but they're otherwise, their O2 set's a little bit low, we found that's not really associated with adverse outcomes. Usually if a patient is, significantly hypoxic, they will tell us that there's a problem. And I think there also needs to be work on protocolizing responses. And then finally, once these systems are set up, institutions really need to individually audit the barriers to timely responses. Again, just because you have it set up doesn't mean it's working well. It's really just kind of the start of an ongoing process. So that's all. Thank you.